Good morning, everyone. It's great to be here again at the Akapan Capacity Development Series. We've had a couple of series in the last group of months, and it's good that we're here again. And today's meeting will be every bit as exciting, if not more, than the last meeting that we had. Today, we're going to be talking about adolescent addiction, and we have two speakers. In the traditional template that we have had, one of the speakers is speaking from Nigeria, while the other speaker is across the Pacific, will be talking to us from the US. At this point of the meeting, I'll hand over to our very own dear president of Akapan, Dr. Yewande Oshodi, who will be walking us through what we're to expect today, as well as the speakers that we have. And right now, the voice you will hear right after this will be none other than that of our president, the visionary Dr. Yewande Oshodi. Thank you, everyone. Please stay muted up until the time where we're supposed to have some feedback. And while the speakers relate with us, please remember that we can also maximize the chat room by putting our questions there so that while they're done, we can have a seamless flow of the Q&A in between the speakers, as well as after the second speaker is done. So thank you very much, everyone, for attending the Capacity Development Series. Right now, we'll listen to our very own president, Dr. Oshodi. All right, very soon we'll hear the voice of Dr. Yewande Oshodi. She'll be speaking to us in a minute. While we wait for her, it would be most appropriate to mention that our speakers are already here with us, and it's so good to see our speakers logging in right now. Dr. Yewande Oshodi is right here, and she's the best person suited to introduce to us the seasoned speakers that we have for the day.
Thank you very much, Dr. Omotosho. And I'd want to say a very good morning to all our participants and our guest speakers that have joined us today for this Akapan Capacity Development Series. Just by way of background, it's nice for us to know that we started this virtual sessions in an attempt to further bring us all together as individuals interested in child and adolescent mental health, and also to begin to increase our capacity via, sharing of information and experience and knowledge and the science around what we do. So we're all welcome to the July events. Today we have two wonderful speakers who have taken time out of their very busy schedules to prepare to talk to us about adolescent addiction. The first speaker, Dr. Folorunsho Nuhu, will come up in a few seconds once I'm done, and then Dr. Kweju Shimoyim. I will start by, and I'll introduce each of them properly. Dr. Kweju Shimoyim is based in the USA, while Dr. Nuhu is based up north here in Nigeria. So I'll start by introducing Dr. Folorunsho Nuhu. Dr. Folorunsho Nuhu hails from Asa local government area of Kwara State. His MBBS was obtained from University of Ilorin in Nigeria. He did his residency training at the University College Hospital Ibadan and completed his program in 2007. He also possesses membership of the Nigerian Institute of Management, and he is a faculty member of the National Postgraduate Medical College of Nigeria, the Faculty of Psychiatry. Dr. Nuhu established the Child and Adolescent Psychiatry Unit at the Federal Neuropsychiatry Hospital in 2008, and he's currently still the head of unit. So he has been growing the service over there, making an impact. He is actively involved in training of doctors at different levels and post-basic psychiatry nurses and student nurses. He's conducted several research works in the hospital and has over 40 publications in peer-reviewed journals. He is the Kaduna State Principal Investigator of an NIH-sponsored project titled Bridging the Childhood Epilepsy Treatment Gaps in Northern Nigeria. So we see that he is really committed, not just into service for child and adolescent mental health, but also research. He is a reviewer of some local and international journals, and he has been an examiner at different levels of the postgraduate psychiatry exams in the Faculty of Psychiatry of the National Postgraduate Medical College. And he's happily married and has children of his own. So without much ado, I want to invite Dr. Nuhu immediately to the mic. This meeting is going to take about roughly an hour and a half maximum. And so we will be very time conscious, but we hope that everyone will benefit something at the end of the day. Over to you, Dr. Nuhu. You're welcome. A round of applause as he comes to the microphone. Virtual round of applause.
Thank you very much, everybody. Thank you, Dr. Oshodi. Let me also thank some of our elders in child and adolescent in Nigeria. I will start with Professor Omigbodun. I will thank Dr. C.O. Ogun, Professor Ayimode, and my sister, Dr. Majid Bello, and another brother of mine, Abdul Malik Jubril. Let me also thank our very active young child psychiatrist, Dr. Motosho. He's an learning product like myself, so I'm proud of him. So thank you, everybody, and I welcome you all to today's presentation. Am I starting?
Sorry, Dr. Nuhu, we can't hear you. You need to check your mic. Did you mute it inadvertently? Please check your mic. Hello? At the bottom of the screen. Yes, we can hear you now.
Okay, thank you very much, everybody. Thank you very much, Dr. Yeah, thank you, Dr. Oshodi, the president of ACAPAN. I want to acknowledge our leaders, our mothers, elders in ACAPAN, Dr. C.O. Ogun, Professor Omigbodun, Professor Ayimode, my sister, Bello Majid, and my brother, Abdul Malik. And I want to also acknowledge the good work of our very active Dr. Motosho. So I welcome Dr. Simoyo and every other person that is taking part into this program. Thank you all and welcome. Hello?
Hello? We can hear you, sir. We can hear you. Okay. You're on the call. Thank you so much, sir.
Thank you. Thank you. So can I start the presentation?
Yes, please go ahead, sir.
Okay.
Yes.
Yeah, I'm sharing my screen. Yeah, can you see my screen?
Yes, we can see your screen.
Thank you very much. Once again, I welcome everybody. This morning, we'll be discussing overview of adolescent addiction. And I'll follow the outline below, introduction, where we will describe what adolescents and addictions are. We're going to talk about the types of addiction. We'll talk about consequences of addiction and the summary of treatment modalities. Adolescent persons are persons between the ages of 11 and 19 years. That is the adolescent and proof interrogations. They don't because addiction, on the other hand, physiological dependence on a substance or individual. It is also described as a compulsive drug use or compulsive engagement in rewarding behavior despite negative consequences that are very, very obvious. Various addictive behaviors have been classified under different rubrics, but today we're going to focus on psychoactive substance addiction and pathological gambling. These two are recognized by the classification method of ICD and DSM. The third is internet addiction, which is being considered as a future entity in DSM-5. There are some not too researched behavioral addiction, which we just mentioned. They are sex addiction, exercise addiction, shopping addiction. In non-addictions, the central focus is their ability to get reward through the reward pathway. And this is what usually responsible for the individuals craving and wanting to have more by way of taking more and more of the substance or engaging in more and more of the activities that they feel bring pleasure to them. These are the three common addiction behavior: the psychoactive substance addiction, internet addiction, and the pathological gambling. Let's start with psychoactive substance addiction. Drug abuse among adolescents is of public health importance. In Nigeria, about 22% of adolescents use tobacco, and about 15% use alcohol, 7% use sniffing agents, 6.7% use amphetamine and ephedrine, 3.6% use cocaine, and 3.4% of adolescents in Nigeria use cannabis. There's a recent study in Kaduna, and the findings are very, very similar to what I described above. In the United Kingdom, 12% of their adolescents use substances. What is substance dependence? It is characterized by irresistible urge, that is craving. And it's this craving that makes the adolescent or whoever is addicted to want to take the substance, and they can do anything to get the substance. For example, an adolescent who is addicted to a particular substance can sell his properties, can steal, can rob, can even engage in sex for money to buy drug or sex to procure the drug. Then addiction is also characterized by tolerance, withdrawal symptoms, repeated unsuccessful attempts to stop or cut down, and neglecting other sources of pleasure. For instance, food and sex is not the priority of an addicted person. Rather, it is the drug. There's also the persistent use, despite having very, very obvious, serious physical problems. For example, someone whose liver function test is deranged and he still continues to use alcohol. The DSM-5 subdivides addiction into mild, when the symptoms are between 2 and 3, moderate with 4 to 5 symptoms, and when the symptoms are 6 or more, it is described as severe addiction. So let's go to pathological gambling. Which one of these are we familiar with? I would rather say that all these 6 are very common in Nigeria. But I will mention that Bet Naija, Naira Bet, WGB, SureBet, One Card, and Merry Bet are quite common, and our adolescents in Nigeria and the youth are engaged in all sort of, this avenue to gamble. Pathological gambling begins in adolescence for men, but it's usually later in life for women. Pathological gambling is far more common in men than women, and it often follows a waxing and waning course. 3 to 5% of American population are problem gamblers, and it's been described that the lifetime prevalence is 0.4 to 1%. In this country, in a study conducted in Imo State, over 57% of secondary school adolescents had gambled at least once in their life. The criteria for diagnosing pathological gambling include persistent and recurrent problematic not of the with the criteria with increasing amount of money in order to achieve a desired result. The adolescent is restless or irritable when attempting to cut down or stop gambling. This adolescent has made several unsuccessful efforts to control or stop gambling. The adolescent is often preoccupied with gambling. It's often gambles when feeling distress, and after losing money, the gambler comes back the following day to even gamble his chasing life to concentrate of gambling. He has jeopardized or lost a significant relationship or lost a relationship and the adolescent relies on others. That's characterized by the life of the individual. The gambler tries to reclaim their losses. The gambler uses it as an escape route from other stressful life events. The gambler is deceptive about the gambling habits. There are physiological signs if the gambler decides to stop or cut down, such as sweating. There's increased frequency or level of gambling, and the gather illegal activities to fund the gambling. So let's go to internet addiction. We can look at this boy, this young boy. Apparently his brother was trying to pull him away from the laptop, but you can see that he continued to concentrate, not even looking at the brother who was struggling to take him away. Now, over 140 million Nigerians use internet as at May 2020. Most users are young people, and the studies in Nigeria have revealed the prevalence 10 to 14% of undergraduates who have had severe internet addiction. Internet addiction can also be described as compulsive computer use or pathological internet use or internet dependence. This entity has not been recognized by either ICD or DSM, but it's a future consideration for DSM-5. 5 types have been identified. They include cyber sex, net compulsion, cyber relationship addiction, compulsive information seeking, and computer or gaming addiction. The symptoms and signs of internet addiction include preoccupation with the internet, feeling the need to spend more time online to achieve the same amount of satisfaction, repeated but failed attempts to reduce internet use, feeling of irritability, depression, and moodiness when internet use is prohibited, using the internet for longer period than planned, putting a job or relationship at risk so that the individual can use internet, and lying about amount of time spent online. The internet addicted person also relies on internet to regulate or improve his mood. So what are the consequences of addictions generally? Physical illnesses can occur in people using substances like alcohol or cigarettes. These complications can include cancer, high blood pressure, heart disease, and brain damage. Other mental issues like psychosis, depression, amotivational syndrome, cognitive impairment can also result from use of substances. Neglect of self is another recognized consequence. Loss of important relationship, lying, stealing, frequent legal problems, embarrassment of family and friends, and jeopardizing functionality at school, work, society, and home. How do we manage an adolescent with addiction? The hallmark of treatment is prevention. Prevention can be at the primary level, secondary level, or tertiary level of prevention. However, the bedrock of treatment is to do a detailed assessment of the individual, taking history, conducting a physical examination, so that we can make appropriate diagnosis. We can identify factors that are predisposing, precipitating, or maintaining the addictive behavior, and so we can plan adequate treatment for the adolescents. However, all our interventions must follow the biopsychosocial approach. Investigations, physical, psychological, and social investigation will help. Now, we should also take note of comorbid physical conditions which should be treated appropriately. So, also comorbid psychological problems. There may be need to use medications, especially for psychoactive substance addiction. We may need medication for detoxification and medication for treatment of comorbid physical and psychological conditions. We must do drug education, and specific psychological interventions for all forms of addiction can be very, very relevant. This may include individual therapy, group therapy, and of course, behavioral modification. Ladies and gentlemen, thank you all for your time. God bless.
Amen. Thank you very much, Dr. Nuhu, for the session. Please kindly indicate if you can hear me.
Yes, I'm hearing you.
All right, sir. All right, sir. Thank you very much for the succinct presentation, and thank you for keeping to time. And that's one major reason we would have the benefit and the opportunity of harvesting feedback from our audience. I'm sure that from such an important topic, we'll have questions and contributions. I see that already in the chat room, we're having some comments. In fact, some people did some private chats where they had asked whether some adolescents could also join this meeting. So I'm sure that we have a heterogeneous group, and we would like to have feedback at this time. So if you have questions, please, now would be the time to raise those questions before we then listen to the second speaker. Thank you, everyone.
So I think we'll take the questions at the end, or do you want us to take it now, Dr. Motosho? Hello?
All right, at the moment, it appears that Dr. Oshodi is also speaking. So we'll listen to her
I was
coordinate
asking.
the interval
No, I was
between
just asking.
this point and the next speaker.
Okay, so we will go on to the next speaker, Dr. Motosho. Is that correct? And we take all questions at the end.
Dr. Oshodi, is Dr.
that
Oshodi with
fine?
us?
I'm here. Hello, can you hear me?
Hello, Dr. Nuhu.
Hello? Hello? I'm here.
Yeah,
Hello?
Dr. Lu is here. Dr. Ashu deliver her lecture,
Hello,
and
is
all the
everyone
questions
here?
can be taken.
All right, I'm still trying to hear you here. What it's saying is the bandwidth is possibly low over there. So I'm not, that's why I'm trying to confirm if you can hear me, sir.
Can you hear
Yes,
me?
Dr. Matosho, we can hear you.
Okay, sir. Okay, sir. All right,
Can anyone
sir.
hear
So
me?
I've tried to check if we have any questions. It appears that people
Yes, we can hear you.
Okay, thank you very much. So it appears that people would rather have their questions, harvest
Can
the
anybody hear
questions
me?
at the end of the presentations.
Yes, ma, we can hear you, ma.
Okay,
Yeah,
all right.
thank
So speaking at the moment,
Omotosho.
Dr. Bello Majid.
You are talking at the same time with Dr. Oshodi, but Dr. Oshodi couldn't hear you.
Yes.
Oh, she
All right,
couldn't
I think
hear
we can
me.
hear ourselves now. Thank you, everyone.
Okay.
These are some
She's
of the
speaking at the moment.
challenges
Can
of
you
the
hear
new
her,
normal.
please?
Yes.
No, I could hear
Can
you,
you
but
hear
you
her,
couldn't
please?
hear me.
I'd like
I
to
think
know
we
if you
can
can
hear
hear her.
ourselves now.
We can all hear Dr. Oshodi,
Okay,
but it seems Dr.
so we'll
Oshodi
listen
cannot hear
to
her.
Dr. Oshodi. Oh, okay.
Okay, can someone tell Dr. Motosho to let me talk? I think he cannot hear me.
Dr. Omotosho, can you hear? Dr. Omotosho, can you hear me? Dr. Oshodi, want to continue talking, Dr. Omotosho?
Okay, I can hear you, Dr. Bello Majid.
Dr. Omotosho, Dr. Oshodi said we should continue.
Right, let's, I think.
So that will take questions.
Okay.
Dr. Omotosho. Okay.
Okay, there's a bit of a challenge now. Dr. Motosha can't hear me, but I could hear him. But it seems like other people can hear me. If that's the case, then should we go on to the next speaker? And then we take question and answers after. That's the plan. If you can hear me, can someone just say, yes, we can hear?
Yes, we can.
Okay, thank you. So I'm going to introduce the next speaker so that we can, in the interest of time, move on, and then we'll take the questions and comments at the end. Our next speaker is Dr. Olakweju Shimoyong. Dr. Shimoyong is the founding director of the Center of Excellence in Research at Caron. She joined Caron as a medical director of research in February 2020. Before joining Caron, she was the associate medical director at Geisinger Marworth Treatment Center in Waverly, Pennsylvania, and the program director of Geisinger's Addiction Medicine. I hope I am getting the pronunciations right.
Geisinger.
Geisinger, okay, thank you, Dr. Shimuya. She was also a member of the founding faculty of, this Geisinger is not going to let me rest, Geisinger Commonwealth School of Medicine, formerly the Commonwealth Medical College, where she held the rank of Associate Professor of Family Medicine and Epidemiology. She's currently an Associate Clinical Professor. She's currently a Clinical Associate Professor in the Department of Psychiatry and Behavioral Health at the Penn State College of Medicine. She earned her medical degree from Penn State University College of Medicine after she completed an internship after which she completed an internship in psychiatry, family medicine at the University of Pittsburgh Medical Center, Western Psychiatric Institute. She completed her family medicine residency at the Penn State Good Samaritan Hospital and community medicine residency program. The interesting thing about Dr. Shimoyo is that prior to her medical training in the United States, she received a dental degree from the University of Ibadan in Nigeria and a Master of Public Health degree from Johns Hopkins University, Bloomberg School of Public Health. And she's board certified, and she's also been an Erasmus Mundus Scholar in France and the UK. She's volunteered on several mission projects in Nigeria and Haiti. She's a member of the Addiction Medicine Sub-Board of the American Board of Preventive Medicine, and she also has obtained several scholarships and awards, including the Emerging Leader Award from Family Medicine Education and American Association of Medical Colleges of Nickens Faculty Fellowship in 2012. Dr. Shimoyo is a person of many parts, as we can see, and she has consistently been committed to the issues of child and adolescent mental health issues, particularly adolescent addiction, and she is committed to supporting us also in Nigeria. So, without much ado, I want to invite Dr. Shimoyo to the microphone.
Well, thank you so much, Dr. Oshodi, for that introduction. Can you all hear me?
Yes, we can.
Yes, we can.
Thank you. All right, and thank you, Dr. Nuhu, for that very nice overview of adolescent addiction. I'm going to be talking about adolescent addiction, but with a focus on the brain and why adolescents are at risk and why they behave the way they do. So just give you a minute or so to look over my the learning objectives. So I'm going to talk a little bit about the epidemiology. And again, I'm glad that Dr. Nuhu had statistics for Nigeria, because I don't have those numbers. I'll be talking about epidemiology in the US. And then we'll talk about the neurobiology of the adolescent brain and risk factors and strategies for treatment and prevention. Right, so why do we need to focus on adolescents? Well, there are a number of reasons, but one reason is that they really are at a higher risk of substance use disorders. And when they do have them, they tend to have greater severity. So let's look at this case study of a young male. We're just going to discuss him very briefly, and then towards the end, we'll come back to him. All right, so a 16-year-old male who first started using these various substances at the ages listed. So he started drinking alcohol at the age of 13, started smoking weed or marijuana at 14, and started using nitrous oxide between the ages of 14 and 15. All right, some of the significant events in his life, include losing his uncle at age 14. He was 14 when his uncle died. And according to him, it was due to some complication that had to do with his alcohol use. So he obviously had a family history of alcohol use disorder. At age 15, he started drinking a lot. He even said that his friend's mother was supplying the alcohol. So this friend was from another country and another culture, and apparently in that culture, it was normal for parents to drink with their kids. That's the story the patient told us. All right, significant medical history. He really didn't have active medical problems, but he had fractured his upper arm, his upper extremity at age 15. Psychiatric history, he had a history of ADHD and anxiety. And then family dynamics. So I keep hearing feedback. I don't know.
Attitude generally is very, very good.
Apologies, there's a lot of noise. Let me just try and sort that out. Dr. Abdulaziz, Dr. Ijarogbe, Dr. Ibigbami, please can you take off your microphones?
Okay.
Dr. Lawal, Dr. Ibigbami, Abdulaziz, kindly mute your microphones. There's a lot of surround noise coming in. All right. I must let you know, Dr. Shimoyo, Dr. Motosho had a bit of challenge with his laptop, so we can't mute the mics right now. So
Okay.
we'll just keep maybe interrupting occasionally to warn people to mute
Okay.
for us.
Okay.
All right, please go on.
Okay, thank you. So in terms of family dynamics, he reported that, oh, his sister was great and they did things together. And at one point he said, oh, my parents didn't really care, but obviously his parents cared enough to bring him into treatment, right? So let's just keep that at the back of our minds as we go through the presentation, and then we'll come back to him towards the end. So here's some epidemiology. There's a survey known as the Youth Risk Behavior Survey, and in 2015, they looked at students in grades 9 through 12. So these are teenagers, and looked at their use in the past 30 days. So those are the percentages. I don't have to read them all, but the percentages of of students in that age group who had used the various substances. So you see alcohol at the top, over 30%, and smokeless tobacco, 7.3% at the bottom. And in between, there's smoking and marijuana. So another study done by Khan et al., looking at 13 to 18-year-olds, showed very similar results in terms of alcohol use. Close to 30% of these teenagers reported alcohol use in the past 30 days. And they also noticed that of those who used alcohol, about 27% mixed the alcohol with energy drinks, that energy drinks tend to be high in caffeine content. So the significant thing about mixing the alcohol with energy drinks is that the fact that they were mixing it with alcohol with energy drinks increased their risk for other substances such as tobacco, marijuana, and stimulants. And I guess the stimulant use shouldn't really surprise us because the energy drinks have caffeine, which is the stimulant. All right, so another study by another Khan et al. Showed that 17% of adolescents had taken prescription medication. Prescription.
Okay, I'm sorry, Dr. Shimoyo. Dr. Ewaoda, Dr. Issa, can you please mute your mics? Dr. Issa, Dr. Ewaoda, kindly mute your mics for us. Anyone on the call that knows Dr. Ewaoda, can you please let him know to mute the microphone? Thank you.
Thank you.
Thank you.
So 17% of adolescents had taken prescription meds without a doctor's prescription. And I know this might not be as much of a big deal in Nigeria, where it's easier to, where you don't necessarily, there are many medications that probably should require prescriptions from doctors that people can get without a prescription. But here it really is a serious issue. And it's another reason why, we tell people to take care of their medications, don't leave them where people can use them. You often have people saying things like, oh, they got, well, in terms of adolescents, they frequently say things like they got medicine from their friends. Sometimes it's from their parents or their grandparents, stealing medications from the cabinets or whatever. So the use of other people's prescriptions is actually a significant problem which needs to be addressed. So cigarette smoking has declined. So that's a good thing. It's been on the decline since 2010. But the unfortunate thing is that what's taken over is the use of electronic cigarettes, or vaping as they call it. So in 2017, e-cigarettes were the most commonly used for the delivery of nicotine among high school students. And in 2018, 21% of 12th graders had vaped, as they call it, had vaped nicotine in the past 13 days. All right. We can't forget about opioids as well, because teenagers use opioids, unfortunately. And a retrospective study that looked at 15 to 19-year-olds between the years of 1997 and 2012 showed that the incidence of hospitalization for opioid overdoses had increased significantly from just under 4%, just under 4 per 100,000 to 10 per 100,000. All right, so why are adolescents more vulnerable? It all has to do with reward pathways and cognition, and that's what we're going to be talking about. So somebody once asked, why do teenagers act as if they're missing a part of their brain? Does anybody want to unmute themselves and see if they can answer this question before I go to my next slide? Why do teenagers sometimes act as if they're missing part of their brain? Anybody want to respond to that?
All right, if nobody's jumping at it, I'll probably then shoot.
Thank you.
Okay, I think it could be because the frontal lobe in adolescents is still developing, and up until the age of about 21, it's not fully developed. So they have some form of pseudo-infallibility where they feel that they're not vulnerable to anything and they can do just about anything. So that may explain part of the dangerous or violent behavior we see in them. And then the psychosocial factor that may be responsible for that could be the peer influence, wanting to impress their friends. And by virtue of that Erik Erikson model of them being in that age of identity versus role confusion, they may want to identify with whatever their friends are doing.
Okay, thank you very much. Do you want to give the rest of the lecture? All right, thank you. So teenagers act as if they're missing, they sometimes, not always, sometimes act as if they're missing a part of their brain because they actually are. You know, their brains are still developing. So how can we expect them to behave like adults? So this is a picture of the brain and it shows, you know, basically the reward pathway. We'll just quickly go to the next slide because I have the same picture on that slide. So what happens when a person uses drugs? Let's say they're using an opiate, for example. The opiate receptors are, the opiate receptors get stimulated by the drugs. And then what happens is that the cells in the ventral tegmental area release dopamine, and that dopamine gets released into the nucleus accumbens, which is the pleasure center, we all know. And then that immense feeling of pleasure is what they want to keep getting and what keeps leading them to keep using more and more and more and keep using repeatedly. Now, the prefrontal cortex is what is the part of the brain that deals with executive function and making decisions and you know, being able to say no when you should say no. But that part of the brain hasn't been developed, is still developing in teenagers. So we really can't expect them to behave like adults and to make adult decisions. So they really are very vulnerable. All right, so it's the prefrontal cortex is one of the last parts of the brain to mature. It doesn't mature till the early to mid 20s, as we just heard. And then, okay, so the nucleus accumbens in children resembles that of adults, right? This was according to a study done by, well, the researchers are listed below. So we have the limbic system, which is at its peak performance, you know, dealing with emotions and cravings and urges and that sort of thing. And then on the other hand, you have the orbitofrontal cortex, which is more like that of children. So, you know, so the areas that help them to provide control and context are really very immature, whereas the part that's looking for pleasure, seeking pleasure and enjoying pleasure and that kind of thing looks more like that of an adult. So they're kind of like caught in between. And that lack of prefrontal cortical control leads to impulsivity. And impulsivity, as we all know, leads to, it predisposes to substance use and the eventual development of a disorder. So this is just summarizing what we've just said. I'm gonna, in the interest of time, just move on. All right, and then we've already heard about peer influence as well. So let's look at this particular study by Chine and colleagues, where they looked at the impact of peer influence on teenagers. So they looked at adults and adolescents and they compared them, how their behavior when they were performing tasks alone and in the presence of peers. And they noticed that the adolescents actually engaged in riskier behaviors when they were watched by their peers. So what does that tell us? You know, they noticed that adolescents showed more activation in both the, actually both the orbitofrontal cortex and the ventral striatum, whereas these changes were not seen in adults. So basically they concluded that, you know, peer influence really does affect the adolescents' perceptions of saliency. That's the importance they attach to something, you know, and it obviously influences their behavior and it leads to high-risk behavior. All right, so this is just summarizing what we just said. Decision-making is really affected by social context in adolescence, you know, and those social cues seem to activate the limbic system more strongly in adolescents than they do in adults. All right, so we talked about peer pressure. Adolescence is a time of high stress for many people, so they're experiencing peer pressure like we just talked about. They also have academic demands, school demands. They're thinking about, going to college, going to university, what career am I going to choose? There's also family dynamics. And so adolescence can be a very, very stressful time. There's also a significant level of psychiatric disorders. They may be suffering from depression, suicidality, suicidal ideations, anxiety, ADHD, to name a few. And then there's also a lot of physiological changes going on with the adolescents, as we all know. And they can have increased cortisol levels. We all know that cortisol is a stress hormone. And the hormonal changes that are going on in the adolescents may actually prolong the stress response. So really, it is a perfect storm. And that's why we really have to watch out for our adolescents, because the adolescent brain is still developing and it's neuroplastic. We all know that, it's easier to learn things when your brain is still developing. So in the same way, when a teenager is exposed to substances and makes those associations between substances and the pleasure that they get, the reward that they get, it's easy for them to adapt and to start exhibiting those behaviors that favor their substance use. So basically, the fact that they're still, that their brains are still so neuroplastic puts them at high risk. So in addition to having prefrontal cortex, in addition to their prefrontal cortex not being fully developed, there are also other things that are going on with the adolescent brain. When an adolescent drinks alcohol, they don't necessarily have the same response that an adult would have. So for example, the sedative effects of alcohol are not felt to the same extent in an adolescent, which could lead them to drinking more as opposed to, just taking one drink and stopping there. On top of that, they're also more sensitive to the neurotoxicity that's caused by alcohol. And on top of the fact that their executive function is not yet fully well developed, when they engage in binging, that can also negatively impact the little executive function that they have. And it's also been shown that adolescents that have alcohol use disorder also have a decreased hippocampal volume. So there's a lot going on in the teenage brain. This one research project published by Steinberg showed that it's not that teenagers can't think. Obviously, I'm sure we all know a lot of teenagers who make good decisions and all of that, but it's not that they can't make good decisions. But in this particular study, they looked at teenagers' responses when they were presented with different scenarios. And what they found out that when it comes to a personal decision, when it comes to something that's going to affect the teenager personally, they're more likely to make a decision based on their feelings. Whereas if you presented them with some kind of moral, ethical dilemma, something that was really serious, that sounded serious but was really hypothetical, then they were more likely to use their logical thinking, the logical part of their brain. So it's not that they don't have the ability at all, but it's kind of, their decision making was very, very context-based. All right, so stages of adolescence. I don't think I have to go through this because we've had that during the first presentation, early, middle, and late adolescence. How do we prevent it? Well, first of all, having a very strong foundation in early childhood. It's not going to necessarily prevent it in everybody, but it's very important. Teenagers that have a lot of parental involvement are less likely, again, there are no guarantees, but they're less likely to end up using substances. And also what is considered normal in that society plays a role in terms of what teenagers are likely to do and not do. Also, school-based programs are encouraged to help prevent substance use and promote healthy habits in students. So this is a list of screening tools for those in primary care. I'm not going to read over all of them, but there are a lot of tools that can be used in primary care to identify students who are either already using substances or who are at high risk of substance use. All right, in terms of treatment principles, we want to be sure that what we're doing is developmentally appropriate for the patients at that age, at that stage of life. Confidentiality is a very important factor. With adolescents, it's very important to be sure that we let them know that we're not going to share anything they tell us with anybody, including their parents, unless they or somebody else's life is at risk. Otherwise, we really have to maintain confidentiality. Obviously, our treatment should be evidence-based, and there's a lot of family involvement in our treatment programs, and that's very important because obviously we're sending them back to their family environments, and their family members are going to have to deal with them. All right. We want to be sure that we're addressing whatever mental health issues are co-occurring, whether it's ADHD, anxiety, depression, those need to be addressed adequately. Medications, when indicated, they're not always going to be indicated, but sometimes medications are indicated. And then drug screening, urine drug screening, or other means of drug screening as appropriate should be incorporated. Okay, so we have group therapy, and one way of dealing with this, when the patients come together for group therapy, sometimes they're asked to just to do like a check-in at the beginning, and they're asked about how they're doing mentally, emotionally, physically, and spiritually. We also have individual therapy sessions, and something that I was exposed to here in my current position is something called timeline, where we would have the patients actually review their own life history. So they would talk about how old they were when they first started using whatever their substance is, what was going on in their lives at that time, and what happened after that. Did they get into treatment? Did they not get into treatment? If they got into treatment, did they relapse afterwards? What were the major significant life events? And it's just a way of getting them to look over their lives, their life histories, and see and have a better understanding of what happened and why it happened, and how, what they can do in the future to prevent whatever might have led to their substance use or might have led to their relapse and that kind of thing. And then we have family days. Right now with COVID, that family visits have been suspended, but that's under normal circumstances. There are family days when family members come and participate in programs. Adjunctive therapies include things like music therapy, art therapy, recreation therapy. I'm not going to talk too much about them because I think we're running out of time. But I do want us to go back to the patient that we talked about earlier on. So if anybody who wants to participate should please unmute themselves. This is the slide from earlier on. If you want to discuss what you think is significant, about this patient, what are things that we would need to address, or things that might be complications, things that might complicate his treatment, or things that might be that might actually support his recovery. So if anybody wants to contribute, please unmute yourself and go ahead. Anybody? Hello?
We're right here. I'm waiting for participants to participate.
Okay, so please participate. Thank you.
All right, you may kindly unmute yourself if you intend to speak to this slide. Yes, Dr. Lawal Habib.
Hello, good morning, Ma, for the beautiful presentation.
Thank you.
Yeah, and good morning, listeners. I think from the case study, what I can just deduce from it is that at age 14, the uncle passed away from an alcohol-related condition, which is which shows that there's more of a predisposition to alcohol use in that teenage. Then drinking at age 15, drinking alcohol, drinking a lot, friends' mother supplying alcohol shows that there are perpetuating factors. The friends who are likely to drink as well and the mother supplying them alcohol will perpetuate this problem in this teenager. And this is likely to perpetuate the problems and make it difficult for managing such teenagers. Thank you very much.
Okay, thank you. Thank you. Anybody else want to say anything? So we talked about things that might complicate the treatment, complicate his history.
Also, as you said before, you can see as he has ADHD and you peer pressure, like you can see, like as you said, his friend's mother supplied the drink, showing that it's something that he does with his friends. And as the thing that we do with his friends, mental disorder he has, it's a thing of feeling welcome, like as a group. So if it starts from there and then it develops and the rest of them don't go as deep as he does, like they started together, so maybe the feeling he gets from it is that, okay, when I was doing this thing, I was welcome.
Okay. Oh, thank you very much for that. So anybody else?
Please, I also like to add to it.
Sure.
From the presentation, you mentioned that sometimes adolescents learn this act from peer groups, peer influences, and I think this case we have here right now is more of family dynamics. It's coming from the family. The uncle passed away when he was age 14, alcohol-related condition, and the mother also supplying the alcohol.
His friend's mother, not his own mother. Yeah.
Yeah, friend's mother.
Yes.
All right, okay. Then it's still within the context of peer influences. Yeah, thank you.
Okay, thank you.
Yeah, please, I quickly want to add that also the parent didn't care. There was nothing like chastising him or telling him to stop, or this is not good for your health, or it's going to affect you later in life. So they just allowed him to continue with that. It's only the sister that was close to him that was also encouraging him and try as much as possible to stop him from doing that. And that might not be able to do much because she's just a sister. So she might not have enough influence on him as the parent would have done.
Okay, thank you.
Hello.
Yeah. Anybody else speak?
Dr. Shimoyo.
Hello, good morning.
Dr. Shimoyo. Dr. Shimoyo.
Yeah, you have to go on.
Can I make a suggestion, please?
Sure.
Can I make a suggestion? I think if anyone wants to contribute, they should raise up their hands because we have several mics unmuted now and there's a lot of noise. So can everyone kindly mute their mic back? So if there's a call for anything, you just indicate with the hand raised and you'll be called so that we can control the noise. Thank you. Phoenix, okay.
I think
Thank you.
one other was trying to talk. I think one other person was trying to contribute, and I wanted a chance, but I don't know.
Okay, let me take a look at that. Ayo Ajayigbe. So I think that will be the last contribution before we go on. Okay, please go on.
Thank you so much. I'm Hayo Ajayigbe, clinical psychologist in Abuja, Nigeria. So I'm looking more at the family dynamics and the past psychiatric history, which is the ADHD and the anxiety part. So I just joined like 15 minutes ago, but have we been experiencing or have we have any history of the ADHD or contributed to the ADHD before the behavior started, or I mean the addictive behavior started, or after? Because if we don't take care of this, help him to treat this ADHD or other psychiatric issues, then it's going to be a form of a perpetuating factor for the addiction. Then the family dynamics, when it comes to addiction management, I always try to not look at what someone has done wrong or what someone has done right. The family may not really even understand. So maybe we should actually invite the family and do a proper psychoeducation for them and help them see how their behaviors has been contributing to the life of this patient in question. And even the sister that was great, we do things together. The sister also can be enabling the behavior, and the sister can also be a positive strength or protective factor for him if properly used. So for me, I'll be coming from the perspective of doing a detailed interview on the ADHD and helping with the management and the family. There should be a family therapy, because if that is not taken care of, even after recovery, if the family is not taken care of, it will act as future relapse factor for this patient. Thank you so much.
Excellent. Thank you so much. Thank you so much for all your great contributions. I think you've made excellent points. I don't even need to talk anymore about this because I think you guys have covered it. I just want to mention that, you know, the patient, he did say my parents didn't care. And while that might have been true to some extent or true in certain circumstances, I don't know that that was necessarily always the case. Again, sometimes we have to take what patients say seriously, but there are times when they do say things that may not necessarily reflect the truth. Okay, so yeah, so we've talked about the stressors. He talked about, nobody mentioned the fact that he broke his arm. He broke his arm, which probably was not, it didn't seem like a very significant thing. He just broke his arm, but he talked about how when he broke his arm, he ended up needing to smoke marijuana daily. He didn't want to go to school. He just wanted to get high and watch Netflix. He ended up needing the weed so badly that he needed it to eat or sleep. So having a medical complication, even something like a broken arm, can really contribute to substance use, unfortunately. And he talks about, I didn't mention this earlier, how he actually started stealing alcohol from his parents. Again, why were the parents leaving alcohol, you know, making it accessible? So that's the question. You know, invited girls over, got drunk. And again, I say the parents had to have cared because they ended up sending him to treatment. So thank you so much for your contributions. That was great. But to just recap, what is going on with adolescents is an imbalance. It's an imbalance in terms of the parts of their brain that deal with making good decisions and the parts that deal with excitement and emotions and feelings and getting high. And again, sometimes it's just an imbalance in their environment. If there's, you know, if they have all the stressors in their lives, too many stressors in their lives, and they don't have adequate support, they don't have an adequate support system, they don't have a stable family environment, they don't have a supportive school environment, they're being bullied at school, they're being stressed with schoolwork. All these things can lead to poor decision making and unfortunately to drug use and unfortunately to drug addiction. So a final word. Adolescence is a very distinct phase of development. We have to remember your teenagers are not little, they're not overgrown children and they're not little adults, they're teenagers. They're just that, they're adolescents and they have their own unique needs. In our treatments of them, in our interactions with them, we need to understand where they are and try and meet them where they are and work, like we said, work with their families, work with their, you know, if possible, work with their teachers, with the school system, and just to make sure that we create an environment where they're less likely to use substances, but even if they do, that they get the adequate treatment and that they, you know, are able to stay healthy and sober so that they can go on to live productive lives. So I think that is the end of my presentation. I don't know what this funny thing that appeared on my screen is, but that's my last slide. Thank you so much for listening and thank you for your participation. Okay.
Thank you. Thank you so, so much, Dr. Shimoyo. I'm sure we're all clapping from wherever we are, far and wide, from Lagos to Kano to Abuja, all around the world. Thank you very much. And at this point, we're going to invite questions from the members, the participants. And I think our speakers will be more than happy to respond to the questions. So you can indicate by raising up your hand. Okay, so Maiduguri, someone's from Maiduguri there, you know, so we cannot afford to leave Maiduguri out when we say thank you, when we acknowledge those present. So we would want people to put questions in the chat and we'll try to go through them as quickly as possible. Before we do that, I just want to, you know, maybe set the ball rolling by just saying a thing or two about some of the comments that the presenters, you know, have have highlighted and raised for us. You know, understanding the biology of the adolescents can definitely begin to guide us as we think about interventions also. Just realizing that, you know, they are actually challenged, you know, with the nature of their brain and the stage at which it is. That's what Dr. Shimoya has shown us here in this talk today. Dr. Nuhu highlighted, you know, interventions and how we treat, you know, primary, secondary, and tertiary. And I think as we all begin to think about adolescent addiction, which is beginning to be a big issue here, we should be thinking about policy, about how we can influence and guide policy at all of these levels, primary, secondary, and tertiary. Primary will be a general thing to prevent, you know, them starting at all. Secondary will be for those that, you know, are at risk, and tertiary for those that are already using. So because it's important that we leave these meetings or these sessions with an additional strategy that we're going to add to what we're already doing. Two other things I want to maybe highlight for us from all that we've heard is, you know, the interventions that we put together for adolescents must also feed into the way their brain works. Their brain is fed by a lot of enjoyment, pleasure. So what we're doing for them must be fun and pleasurable also, because they're driven by that. They're driven by that reward thing. So you give them a boring program, something that's not age appropriate, it's not going to fly. Then secondly, the fact that peer influences, we all know that peer influences matter, but with this information now, remember Dr. Shimoya told us that, you know, when they're in the presence of their peers, am I correct, Dr. Shimoya? It seems like they even take greater risks. If I remember, it's almost like they just go berserk once they're in front of their friends. So that should tell us as child and adolescent experts, and also as parents, you know, who do you leave your kids with? You know, where are these kids? How do they spend their time? In what company of peers are they? And what are the supervision strategies around them? You know, so that we're thinking about that around our intervention. When we talk about supervision, it also feeds into parenting. One of the slides Dr. Shimoya shared spoke about something about early intervention. Essentially, it must start from early on when we're parenting these children, or when our patients' parents, you know, we're parenting, or when we're thinking about prevention as a whole. We should set that up very quickly. There are studies that have shown that adolescents that do not have enough supervision, you know, may actually be at higher risk because they have unaccounted for time with inadequate supervision. They're driven by this reward and pleasure, you know, setting of their brain, if I could use that, and that puts them at further risk. All right, I'm going to then, I think we have quite a few comments in the chat, which I will allow Dr. Motosha, if he can, I don't know if he's there. Dr. Motosha, are you there? Okay, what investigation should be done for internet gambling and pathological gambling? I think this is for Dr. Nuhu. Dr. Nuhu. Dr. Nuhu, are you there? Can you unmute yourself?
Yes, I hear you.
Okay, so we have that question about investigations that can be done for internet and pathological gambling. And we also have, if internet addiction and regulation was discussed, yes, it was discussed, any suggestions and tips of how to go about this without being in a fight and getting them to understand how bad this can be for them. So we have two questions regarding internet addiction. I think it's really the issue of the now, because our kids are at home and we do have lots of adolescents at home on the internet. Thank you, Dr. Nuhu.
Thank you very much. The question on investigations, like I said, it should follow a biopsychosocial approach. There may be, we may not have specific biological investigations to do for internet addiction, but a lot of psychological investigations must be done. What are the factors that are motivating these adolescents to go into internet overuse? And what are the consequences this use of internet has had on the individual and how is their home environment contributing. So these are the investigations that we need to do, essentially psychological social investigations for internet addiction. But the biological investigation generally will go for the substance abuse, alcohol, tobacco, cannabis, and co. But the investigation I mean for internet addiction is essentially psychosocial. Thank you. The legislation for or against internet addiction, I am not aware of any yet. But if through our advocacy, continuous education of the populace, and of course the government, a lot of enlightenment program, maybe one day we may make them to formulate a policy. But Nigeria, I'm sure such policy formulation to now apply it may also be a challenge. But
How can we help them know? How can we help the adolescents understand that overuse of the internet can be bad for them without getting into a fight? What do we suggest?
Thank you very much. Like what I said, continuous education of the populace, enlightenment programs on radio, television, so this or sending messages in social media about the negative effects of internet addiction may help, because that would mean that we are giving them adequate information, which we feel they should be able to utilize. And this one should be in a very supportive manner, not criticizing them, not being judgmental, but to let them know that we empathize, we recognize their problem, and these are the ways by which they can get out of the problems. Thank you.
Thank you very much, Dr. Nuhu. I think on that note, we need to bring this meeting to an end. I suspect that there may still be questions. We will leave the chat room open for maybe 2 more minutes to receive questions, and which we'll ask the speakers to respond. I will ask Dr. Shimoyo to take this last question so that we can wrap up. We have overshot our time already. What forms of life skill intervention do we have? How can it be made part of clinical practice? Dr. Shimoyo, please. That's the final question.
I think that as part of our treatment programs, well, having a support system is very important. So we usually encourage our patients, even the adolescents, to have a sponsor, somebody who has been through an addiction, who is in recovery themselves, So that's one thing. Have a sponsor that you can communicate with regularly. Involve the family, educate the family. We've talked about this before in terms of what the addiction is, because a lot of people don't really understand. They think that their family member is just making poor decisions. So they need to understand that it's a brain disease, and they need to understand what they need to do, what they can do to support this person, especially for a teenager, to support them. As far as teenagers are concerned, they're usually in school, right? So we want to make sure that we're helping them as well, making sure that their school environment is supportive, and making sure that that they're doing well, or they have the support that they need in school, and having goals, having academic goals, having them to think about the future, what they want to do with their future. Sometimes just having a goal, having something that you're aspiring towards is a strong enough motivator to stay away from substance use. So those are just a few examples. And of course, staying in treatment, staying connected with your support system, which includes your sponsor. If it's therapy, staying in therapy, those are all very, very important. We tell people, avoid people, places, and things. I tell patients it's not just a cliche, it's really real. So avoid hanging out with those peers with whom you used to use, or going to the places where you used to use. And so it's a very, it really is a multifactorial issue. So we have to look at all the different aspects of addiction, all the different aspects of this person's life, and see where we can help them to develop those skills and help them to get that support and to maintain that support so that they stay healthy and sober and live productive lives. So I hope I've answered the question. We can always continue offline, I guess, but thank you very much. Thank you again for your—
All right, thank you. Thank you everyone once again. And this brings us to the very end of this, this session. And we will meet with everyone again next month. We'll put up notices, and you're all welcome to join us. The slides, I think, will be available. Dr. Shimoyo, Dr. Nuhu, can we commit to getting the slides from you?
Please,
okay.
go ahead.
So Okay, so we will share the slides. If you do need the slides, please check on the chat. Our email is there if you are not a member of ACAPAN. And if you're a member of ACAPAN, the slides will be up on the chat group. Till next month, we say goodbye.
Okay.
God bless and
Bye-bye.
be safe.
Thank you.
Thank you very much. Bye-bye.
All right.
Thank you, Dr. Nu, Dr. Shimoyo. Thank you. Bye-bye.
Thank you. Bye.
Bye. Thank you, Dr. Motosho, for always.
Thank you, Ma.